So happy to welcome you to our Lunch and Learn for today. Jamie, go ahead and kick on your camera as well and your microphone. So I'm so pleased to have Dr. Jami Furr as our presenter today. Her topic is Internet Delivered PCIT. So far, it deserves a label praise. By way of introduction, Jamie and I go back a long ways. Uh, I don't know, 10 years or so, something like that. Jamie got her PhD with Phil Kendall at Temple University, and her introduction there, of course, to anxiety disorders and other things as well. And then we were fortunate to have Jamie come to the NYU Child Study Center on her APA internship, where we got to work together. And she did me the honor of staying on as a postdoc with me for a while at Child Study before moving on to Boston University at the CARD, the Center for Anxiety Related Disorders, and then her final or last leg of most recent leg of her journey down to Florida International University, where she's actively involved in the MINT program and an incredible training program for up and coming psychologists and doing great clinical work. And we've shared a passion for so many things, including parent child interaction therapy, our work with selective mutism together, so, Jamie, without further ado, I'm going to turn over the floor to you. I will keep our guests coming in the room while you take over the presentation. Thank you again for sharing your time and your expertise. Oh, by the way, it is, as of a minute ago, 82 degrees in Miami, while it's 37 and snow and slush here in New York. So, at least today you made a great choice.
Yes, I'm sorry to hear you guys have a nor'easter coming through. Hopefully everybody can hear me okay. Thank you so much, Steve, for inviting me to give this talk and to talk with all of you at your group as well as the country. It's exciting that we can do these things in the spirit of technology. Um, I'm going to walk through a little bit about why we need internet delivered services and then talk through some data that was collected as part of John Comer's K Award looking at internet delivered PCIT. And then we'll talk about a new venture that we are currently in the process of conducting an RCT for, looking at using some of these skills from PCIT to deliver anxiety-based treatment for young children online. So, um, so obviously we all know that technology can be extremely useful, and right now there's a kind of crisis in the sense that there's much less availability to the mental health care that we need and getting that out to those who are affected. So, but we know that there are treatments that can work. And so we have, obviously, there has been years and years of studies collected on parent child interaction therapy. Um, Obviously, you can go to PCIT International and find all of these amazing studies. So we know that it works. So our questions are not necessarily do these treatments work, but can we deliver them online and can we be effective in delivering them? Because although we have these great treatments that work, we're not really kind of getting all of these messages out there. So obviously we've got a lot of trees kind of falling in the woods and no one's really hearing them. So what we know from prior work is that only 40% of Americans right now who have a mental disorder received treatment, and less than a third of those getting treatment actually got it from a mental health care professional. So, and typically what we find is that there's a huge range in the delay of treatment from people trying to seek these kinds of services. And typically you're finding that less than 10% are actually able to get to services within the first year of onset, which is pretty kind of heartening for me, at least in this position. So Comer and colleagues have, have done quite a bit of work on looking at kind of the limited availability of mental health care services and finding that, and kind of one of the hardest things is that there's an inadequate number of professionals who are able to provide care, as well as really significant geographic differences in the availability of services. and that the large proportion of the United States and numerous counties, especially as you go into more rural areas, are really lacking psychologists, psychiatrists, social workers, and so they don't have a lot of availability, and they don't really even have at times have people who know what to do for these particular difficulties. And even if they do have a community mental health center, then those places are very kind of understaffed, underfunded, and have a lot of people on their wait list, making it really difficult for families who are even able to try to seek treatment to even get that treatment within a short period of time. So, some significant obstacles that we have seen in terms of getting access to care is, and probably the more well studied, is that obviously cost is a huge factor in terms of people getting to service and being able to afford the services. Obviously, we also have an issue within the United States that our insurance is not really covering as much of the mental health care as it should be in relation to physical health care, as well as transportation. You know, down here in Miami, um, unlike New York and Boston and those other major metropolitan cities, um, the public transportation is really terrible. We don't have a subway. We don't have a T. There's like a couple rail lines, but they don't really go east and west, and we're located in the west. So these people, some of the families who are coming from different areas in Miami, have to take two buses. It takes them 3 hours to get here. I mean, that's just not feasible for families with kids. And there's also another barrier that I think is kind of really coming out, obviously, in the public right now, given the unfortunate shooting that occurred, unfortunately, not far from here in Parkland, is that still such a strong mental health stigma, kind of keeping people who have mental health difficulties from stepping out into the limelight and getting service that they need. So we do see, though, however, that if even if people are able to access the care, that the care may not necessarily kind of be the most indicated practice, and that they're using evidence-based treatment. So we want to try to get those treatments out there to people so that they're getting the treatment that they need and having those treatments be done with fidelity. So instead, you know, what we're thinking about is how can we use all of this amazing technology, just like I can get to you right now live, that we can do the same thing for getting mental health care out to out to the public. Um, so as you can see, there's been a huge increase in internet access and internet use over the past 20 years. So you can definitely see in the blue line that we are really, and in terms of the United States, we're right there with a lot of other countries in terms of really increasing the amount of who has regular internet access, um, close to 80% of the population. You can also see that obviously, as you can think about, even for myself, thinking about 20 years ago, the size of the computer that we had, the size of the phones that we were using at the time, and thinking about how much we have kind of expanded into the number of devices as well as the size of the devices, making it that much more feasible for us to really kind of get these treatments out there and get them out into not only for the families to be sitting at home to access this type of treatment, but that they're able to even go out into the supermarkets and to the libraries and to the playgrounds with these devices, specifically looking at, you know, obviously your iPhones or your iPads and making their way to those sites. Hit a button there. So this is our daughter several years ago. We were in an airport and she looked at the payphone and had no idea what it was. And if you think about where we are today, people don't really see phones like this. I mean, we don't have a home phone, as I'm sure many of you guys don't. And so really, technology has come a long way in terms of um, getting us to be able to access lots of different things. So if we look at kind of where we're going, as I mentioned before, 78% of households in the US have internet, um, and only one in four do not have household internet. And so there are definitely acts of legislature that's working to try to make this more available. Um, and typically, those who come from rural areas, low income families, are showing kind of the most rapid growth in taking on internet, but typically have the lowest access to it. And obviously, the smartphone plans are changing, so we're getting wider range of coverage, more plans that don't require contracts, which is a huge impact for low income families who maybe who do not have appropriate credit checks.
Jamie, can I cut in for a sec?
Sure.
Some folks are having difficulty hearing the audio as is. I'm going to have us switch over to the telephone part for the audio. So if you would,
Hold on one second. Is that better? I just moved my headphones.
folks, type in if that's better.
Is that better? Now that I'm sorry, I realize I moved my. It looks like it's better. Okay.
Easy fix. There we go.
So sorry. Okay. I just feel like I am
You're all set.
getting an echo. Hold on. Okay. So so let's take a look at who is using the internet and who is online. So as
By
you
the way,
can
one more cut in for me. We love to know who our audience is. So while Jamie is talking, if you guys would fill out that survey in the lower part of the screen, that would be really helpful to us. Jamie, please.
sure. So looking at a Pew Internet poll, you can see that there are a lot of people using the internet, and that there's not too many differences, at least in these sort of three kind of racial and ethnic backgrounds. You can see that as people get older, into the older generations, they're not using the internet quite as often. But when you look at the kind of the household income impact, you can see that with those who are making less than 30,000 a year, that you do see a smaller percentage of those people using and accessing online services. Again, our daughter, when she was even younger, our poor son didn't make the cut on this presentation, unfortunately. But you know, let's think about who's using that. I mean, I feel like my daughter is she's 7 now, and she's better at using these devices than I am. Um, and so we can see that there's a lot of teenagers and adolescents who are using the obviously going online and using these services. Um, and again, you can see that that disparity starts to decrease a little bit between those who come from families with less than 30,000 a year. So we obviously know that technology can really kind of overcome certain barriers to care, and our hope is that we can actually really overcome the geographical and distance kind of in terms of people accessing mental health care. So you can see that there's a number of both costs and benefits to using internet-based treatment. Obviously, we can increase the access. We can get them in their own setting. So when you're doing those timeouts, they're doing them in their actual home. It actually allows for there to be reduced stigma. So for those who don't feel comfortable even stepping into a mental health care clinic, this allows them to be able to access this care without feeling that sense of stigma because they're still in their own home. Obviously, we talked about the travel difficulties and transportation issues. They don't have to get to a place. So for a lot of families who work, they go pick up their kid, they go home, and then they're able to access their mental health service. And obviously, the continuity of care. You know, we've had numerous families, even who are taking part in our trials, who they moved part of the way through to a different area, yet we can still access them in the same way because we were providing online treatment. Some of the challenges that are still kind of being hammered out in terms of doing internet-based treatment. Obviously, maintaining confidentiality is a key. You know, and as technology advances, but also as sort of the laws catch up to how fast we're moving with technology, there's new things getting put into place, and there's different platforms that allow for HIPAA compliant and really confidential ways of engaging in web-based services. Obviously, another issue is clinical risk management. Um, we're at times not close to where these people are. So you have to think about the type of populations that you're working with to determine, is this a good population or a good family to work with? in that they're not going to need kind of those crisis services or clinical, they're not showing elevated clinical risk in terms of harming oneself, harming others. Obviously, that distance can be challenging for that. And obviously, helping them to know how to access these services online. Some of them have never used an email before, and so we put together little packets and video instructions on how to access these things, much like how Steve kind of walked us all through on getting set up. Even though I've used this platform numerous times with him before, I still have a number of questions. So you can think about if you've never used something like this, kind of pushing all the right buttons and making sure all the different pieces are working can definitely kind of make it challenging, especially for those who may be older, who have less kind of just technological savvy over time. And also thinking about in terms of whether you have the appropriate kind of knowledge to treat a particular culture. So even if you are from the city and you are trying to work with somebody in kind of a more rural area or from a specific cultural background, again, the same kind of rules apply. If you don't technically have that training to work with that population, the internet isn't going to overcome that barrier. You still would need to seek further training in order to work with those particular populations. Um, what we do know so far is that we do have really good satisfaction with families, both kind of in terms of their working with us as well as provider satisfaction in working with families through the internet, and really strong reliability on the clinical assessments relative to face-to-face assessments. And so we're seeing more evidence in terms of supporting the behavioral telehealth services overall. So what you can see is that there's a really big jump in studies looking at remote technology and mental health care over the last like 12, 10 to 12 years, in a meta-analysis that Comer and colleagues were conducted. And you can see that although the child studies in yellow are growing, still the majority of these studies are adult-based studies. So obviously we're trying to get more of those on the map. And you can see that the largest kind of proportion of studies are examining depression, substance use, anxiety, overall well-being in terms of what those studies were targeting. And so obviously this most likely maps onto sort of the prevalence rates of these difficulties in the larger population. In addition, what you can see is that there's kind of different ways in terms of using the internet, in terms of standalone treatment, where this is potentially accessing a website that would walk you through each of the steps online, where there's no therapist involvement at all. And that's the majority as of right now. About 46% of the studies that they had reviewed uh, were using that type of service, down to 23% using kind of full therapist involvement. And that's sort of the mode that we have been taking, which I'll talk about more in just a minute. And you can see obviously that there is again, a very significant increase in standalone treatments over, from the span in the late 1990s up into the 2000s. So that's really on the rise. And you can see that there is a good amount of rigor in terms of the design that people were using in these studies, using a randomized design in almost 79% of the studies looked at. However, when you look further at these studies, only 66% of those studies, unfortunately, used an inactive comparison. So it makes it even more challenging to determine kind of how well these internet-based treatments are in comparison to an active treatment. So thinking about how telemedicine works, obviously, as more of you may be seeing that even your primary care physicians are using these types of services to deliver treatment and service in real time. And our hope is obviously that we can take the expert care that we all try to provide, and those who are trained even in these kind of more urban settings, and really trying to get the availability out to those who can't access care. so that we're overcoming those geographic barriers, again, reducing the impact of a shortage in workforce in that area. And our hope is that also it's increasing the ecological validity of the treatments because we're accessing them in their own home. So in terms of the hardware and equipment, I can walk through what we tend to use. And because not everybody is going to be able to have access to all of these different devices, but we tend to try to use things that would be simple for families to access, or that they might have already in their home. So we use a a laptop or a desktop computer. Our hope is that they can have high-speed internet connectivity, and I'll talk about what we're providing in another study in case they don't have that. And then obviously you need your webcam and your speakers and all of that. But typically your any laptop now, and then as well as your iPads or tablets, most of those are coming with webcams built in and speakers built in. The most secure way of connecting is actually to do a T1 or T3 line, which is basically a direct kind of using your IP address to connect directly to another computer. Obviously, we can't really do that. And so typically what we tend to use is WebEx, but GoToMeeting, there's lots of different platforms now, Adobe Connect, those kinds of things where you can get a subscription or you can have access to that. Skype, FaceTime, unfortunately, those things are not as secure, although they're free and they're easy to use. So we have definitely used that at times when we can't seem to get our other system to work. Um, so the HIPAA compliant factor can be sort of a challenge, and so you can see that there's some online vendors who are saying that they're compliant, and then again, those web kind of formats or platforms that are geared more towards business interactions do ensure secure encryption. So, which we think is kind of even higher than a HIPAA-based compliance. So, which is why we ended up going with WebEx by Cisco to conduct all of the video conferencing that we're doing as part of all the trials that we're engaged in right now. Um, so obviously you want to follow the same HIPAA laws that you would if you were sitting in your office with a client. But in terms of trying to secure the video conferencing, securing the videos, the data, any storage of confidential information. And so this just walks through kind of, the nice thing about WebEx is that you have to do it through an email. You set a password only for those people who are participating. We have to have a host. And so it really actually kind of allows for different levels of security for families to participate in. Okay. So in terms of still thinking about the legal issues related to using internet-based treatment, unfortunately, as I said before, you can see that there were some guidelines put into place in 2009. However, there has been a huge advancement in technology over the past 8, 9 years. And so again, I think the laws are sort of behind in terms of where we are in our technological advances. So it's not quite meeting up. But some things to think about in terms of remote care is making sure that you have alternate contact information for families when you're starting to work with them, so that if all of a sudden, the video feed drops, that you have their phone numbers, that you have the phone number of their spouse, you have the phone number of grandma in case you need to get in touch with them for some reason. We tend to have families kind of be on the phone as well as on the video conferencing until we know that the video conferencing format is set up and stable at that point. And we also talk about informed consent and reviewing the fact that we are providing services over the internet, that there can be security issues. However, that we're doing everything that we can to try to make sure that their information is kept confidential and that the service is kept confidential. And most families have been pretty willing to engage in this type of service. Um, just some general etiquette in terms of video conferencing that we've learned along the way. In terms of the camera placement, kind of making it, if you have an actual movable webcam, most of them now are built in, so you don't have to deal with this. But again, kind of keeping the camera in the middle, um, that your communication is much more direct and animated, that the hand gestures are supposed to kind of be bigger and broader and slower, um, and that you are um, kind of have light in front of you, which can actually, so I have a window in front of me, which can help kind of make the picture a little bit brighter. And again, if you think about kind of the back and forth, you really want to try to keep that conversation going, just because you're going to need to wait for them on their end. And as you probably all know from if you're FaceTiming or whatnot, that um, the more stuff you have in the background and messing, with things and making noise, as we all discovered, can really kind of mess with the sound quality. Um, so you also want to make sure that there is privacy for them and on your end. So, for example, if you are thinking about doing this in your home or in a private practice, making sure that there's not people walking by while you're conducting the session. And if you are accessing them in a public environment, that you're again kind of just getting consent, verbal consent again, that they are okay going into that environment. We have definitely invited friends over to, if they invite friends over for, let's say, a public practice or an exposure task, then we again will have them speak directly to those other people to get their consent, and we will also consent them again online for being on camera. As I was saying before, kind of having the mic, as we figured out, my mic was not in an optimal place. So getting that set, as well as the lighting. Don't wear a hat because you really can't see your face. And sometimes using more exaggerated facial expressions can also be helpful to get your communication across. And sometimes within therapy, you're really, I mean, I think PCIT is a really great fit for this, because you're not necessarily having to show that level of enthusiasm, because you're technically kind of behind the mirror. But when you're doing the check-ins and check-outs, that's a time to really try to increase the amount of facial expressions you're having, to, that you would be better able to get across in a one-on-one session in person. So obviously this is what, PCIT, your standard situation, would look like in the clinic. We all know that that is very effective in reducing problematic behavior. So what we have done is taking it from obviously in the clinic to doing this online. And so this is a screenshot of what this looks like with one of our therapists, and you can see the therapist portion is in the right lower corner, and then you can very much see the mom playing with the child, and you can see they have a timeout chair ready to go right by the door. So when you're doing PCIT, you want to make sure that you get things kind of set up for success, just like we teach the parents to set the kids up for success. You want to set the room up for success. So making sure that the toys are just like what you would have in your traditional PCIT, but in the center of the room, and talking with the family initially about camera placement, making sure that the camera is either is fully on the play space as well as the timeout chair. If they can do that, oftentimes what's off camera is the timeout room. But as technology advances, we've definitely had families kind of carry either the laptop around or the iPad around, so that we can see the timeout room and have access to that. And we provide families with large floor mics. We did, at least in the initial trial. We're not providing those anymore because now the families are using iPads that we provide to them. So this is another example of what that looks like. So you can see for some families, we can be kind of right on top of them, and other families, we had them scooted back because the timeout chair is actually right behind where the two therapists video is for that particular family. So I'm going to show you some clips And so Steve is going to, I believe, switch things over to show you. First, there'll be a CDI clip.
Great in your description. I love how focused you are on her play.
Oh, it's a castle for Rapunzel.
Great reflection.
Leah likes Rapunzel too.
Great reflection. Really nice job reflecting that back.
You're my best friend, but not anymore. Oh, okay. So she was your friend, but not anymore. Okay.
You're doing a beautiful job following her lead.
Okay. If somebody has straight hair, your best friend. Then mine. Oh, if they have straight hair, then they're your best friend. Yeah. Oh,
great reflection.
That's a good rule. I like that rule. So then I get to be a best friend too.
So she's really, really doing a good job building that tower.
I love the tower you're making.
Great label praise.
That's funny that we found it with our Legos and our blocks.
Really nice enthusiasm. You can tell she's loving this play with you. And you're really letting her know you're listening and you approve of all the great things she's saying.
I love that you stay so calm. Oh, it doesn't work.
Great little praise. That was a really nice little praise.
Oh, it needs.
Okay. So you can see that the mother and the therapist are doing pretty much what you would see in standard PCIT in the clinic. So the therapist is providing that live coaching moment by moment.
Nice ignoring. I love your focus. Good job redirecting your body and eyes away from this. Really nice job staying calm.
Is it easier if I just play them all and then go back?
Beautiful ignoring. And the minute we get an opportunity where she's playing appropriately and being gentle with the toys again, give her toys label. Nice ignoring. Great job ignoring. Body away from thanks for playing so
nice reflection. Good
beautiful differential attention. Nice job. Great label.
Should I switch over to the next one, Jamie?
Nice label praise. You did a nice job following her lead.
Awesome label praise.
Hey, man. Your PPI still to give her another direction. These colors aren't yellow. 1, 2.
Yes.
Thank you for listening. Beautiful command sequence. Nice direct command followed by beautiful label praise. Okay, jump right back into CDI with your CDI direction. Good label praise. Nice label praise. You did a nice job following her lead. Yeah.
Okay, I'm going to pause that one. Steve, can we go back to the presentation because I'll access the Calm one in a little bit? Okay. Yeah, I don't know why it logs me off every time, but okay. So, um, so those are just a couple of clips. Sorry if it was hard to see or hear. But what you could see from the CDI obviously is that you can have the same exact sort of live coaching in the moment and really working on helping them kind of be attentive to all of their positive behavior as well as the active ignoring. It was a little challenging to see, but she was kind of really messing with the toys and kind of throwing them because she was upset. And so the therapist did a great job coaching that active ignoring, and then similar to PDI, um, we didn't get all the way through to seeing the timeout, but just because of the sound, but we definitely can get you clips of that as well. And you can walk them through the timeout as well as the timeout, that full sequence and getting them to the timeout room. Um, Similar to how you would do that here. One of the challenging things is kind of setting up your kind of helping them set up the house to be successful for timeouts. So really trying to make sure that they have the timeout chair in a spot in which we can view it, that it's away from other things that they can't access, just like you would in clinic. And then also working on helping them to establish a timeout room that is, again, feasible to do in their house. So we've talked a lot about setting up baby gates in a hallway, if they can't necessarily turn off the water and those kinds of situations that you talk about in standard PCIT, but you're having to do it, um, right from the get-go, and you have access to looking at their house, whereas other times you don't see it, you just kind of hear about it, and you kind of have to take a guess as to what's going to work best. So the nice thing is at least we have eyes kind of on them and on the house, and we can help them problem solve with that. So so John Comer's K award was to evaluate PCIT over the internet. He had 40 families randomized, 20 to the internet condition and 22 in clinic based PCIT. So at first we could compare how clinic did to internet. And so again, we had 3 to 5 year olds with disruptive behavior problems. And there were independent evaluators who conducted the different interviews as well as conducted the DPICs as you would for any kind of PCIT-based study. And then there were several time points. So there was a pre-treatment evaluation, mid-treatment, and post, and then a 6-month follow-up. As you can see, the mean age of the children was 4 years of age, and the mother was 37 and a half. You can see primarily it was boys that we were working with, and but what we have down here in Florida obviously is a much larger kind of ethnic and racial minority background of families. So you can see that prevalence was not quite as high as the non-Hispanic white families, but definitely kind of on the way up. And you could see there was a nice kind of split on annual household income. So these are the measures that we used to look at responder status. So the CGI, or the global impression scale, looking at both improvement and severity ratings. The diagnostic interview that we used was the Kitty Disruptive Behavior Disorder Scale by Keenan. And then we use the ECB as well, the symptom outcomes specifically. And then parenting outcomes, we used the PPI, which has a positive parenting subscale that will specifically report on the CGAS, which is kind of your overall child functioning, the working alliance inventory that therapists completed as well as families or parents completed, and then treatment satisfaction to see, do they actually like having treatment online. So these are the different types of analyses that were conducted using intent to treat as well as hierarchical linear modeling to look at sort of the repeated observations within child, to look at specifically kind of changes over time, and then also looked at different predictors within each HLM. So as you can see, so CGI-I, which improvement is a 1 or a 2, means that they are kind of very highly improved. And so you can see that the internet-based PCIT showed at the post a 70% responder rate with a CGI of a 1 or a 2, in comparison to the in-clinic, which was 55%. And then you can see kind of the same pattern holds at 6-month follow-up. And you can see with the principal diagnoses, if they lost that principal diagnoses, meaning that at pre they had ODD and at post they no longer had ODD, you can see that those who received internet PCIT, 65% of them lost that principal diagnosis at post and 70% at 6-month follow-up. So you can see really good maintenance of gains, and you can see that same maintenance of gains in clinic-based PCIT. We're just seeing slightly higher rates in internet-based PCIT. One kind of pretty significant finding here is that there was, in terms of excellent responder rates, so where you have a CGI-I of a 1, which is obviously the highest that you can get, so really differentiating those who had some improvement versus really significant improvement. You can see that there's a significant difference between those who received internet-based PCIT and clinic-based PCIT. And this was really one of the bigger findings that we had, so that it really, and our thoughts are that it's likely because we're implementing the treatment in the home, and walking them through all of these different practices in the home as well as out in public, that they were able to, that we were able to see kind of greater response. You can also see through, in terms of the ECBE intensity, you can see a very large time effect as well, kind of going down. There were no kind of condition by time effects or condition effects. So you can see that they both did very well in terms of the ECBE decrease. And similar to harsh and inconsistent parenting on the PPI, that subscale, you can see that those that also decreased significantly over time. And again, there were no type of treatment differences there. You can see on the physical punishment that luckily we also saw a decrease in those over time. Again, no differences between the treatments. And so additionally, what we see is that parents with internet-based treatment actually had a very high satisfaction rating for the internet-based PCIT. It wasn't significant between the internet versus the clinic-based PCIT, but we see that it's a feasible thing to do. People like it. They were able to engage in it. So in addition, you can see that the working alliance scales, that you can see that they were pretty comparable. There were no differences between those in terms of their alliance, which is obviously one huge factor that we worry about, being online and not being in person with them and being able to go into the room with them. And so this is a kind of this means for us, having no difference in that means that's pretty good, good success, both at mid-treatment and at post-treatment. So obviously, internet-based PCIT was associated with fewer parent-reported barriers to care than clinic-based PCIT, which makes sense because we're kind of getting rid of some of those traditional challenges in terms of scheduling appointments and needing to get all the way into, especially here in Miami, as it is in New York, where you've got tons of traffic and people, everybody talks about running on Miami time here, where you're about 20 to 30 minutes late. Obviously, that's not helpful when you're trying to get those sessions conducted. But they reported many fewer kind of barriers to care than traditional PCIT. So obviously we see that we had good alliance, we had great satisfaction, and that they really showed comparable outcomes across the board, and showing even higher rates of excellent responders than clinic-based PCIT. And so it's exciting because it's showing really great promise. And so both, so Dr. Comer as well as Dr. Dan Wagner, who's here on faculty at FIU, who's been doing PCIT for longer than I have. They are now looking at doing
Jamie, about
internet-based
15 minutes,
PCIT
including
for kids
questions,
with
if you're okay
developmental
with that.
delay. So they have a study funded by NACHD
About 15 minutes,
currently
including
to run
questions, if you're okay with
186 kids. And these are kids coming out of early intervention. So they had just turned 3 and they have aged out now of the early intervention system here. And so they are randomized to either receive internet-based PCIT or a usual care type referral. So whatever the early intervention system would typically refer, they're referred out. So I can't give you any data on that. They're still actively recruiting, and so they. But that's to come. I think they're about halfway through their recruitment right now, which is great. And for this study in particular, they're using we kind of upgraded in terms of technology. So instead of we used to send families a floor mic, a webcam, and a Bluetooth device that they would wear. And now they are receiving, for this particular study, for the developmental delay children, they are getting an iPad as well as we can send them a Bluetooth if they need it, but most families have either headphones or their own Bluetooth, and so it's not really necessary at this point. But that's how we've coded. Okay. Sorry? Yes. Yes. We should be good. So just a couple more slides and then we'll be good for questions. So they call it access. And then I wanted to briefly touch on another randomized control trial that we're currently conducting, funded by the Kukis Foundation, is an adaptation of PCIT for kids with anxiety, and we call it ICALM, which is CALM stands for Coaching, Approach, Behavior, and Leading by Modeling, that Tony Pugliapico and John Comer wrote. And both were graduates of the NYU internship. And so the CALM program is 12 sessions of modified PCIT, and I'll show you in a second what that looks like, with anxious youth ages 3 to 8, with kind of your common anxiety difficulties in young childhood. So separation anxiety, social anxiety, GAD, specific phobias. And again, it provides the same type of live coaching that we were using in the other studies. So you can see we provide psychoeducation on anxiety, and we teach them CDI skills. Obviously, as we all know, that CDI is so powerful, and so we wanted for parents to learn how to appropriately attend, especially given the age range, to appropriately attend to the positive behaviors that these kids are engaging in. And even for kids who are anxious, that you can still see a pretty negative coercive cycle occur between the parent and child when they're not engaging in something that their parent wants them to engage in, like an anxious situation. So in the first session, we're doing CDI Teach and psychoeducation on anxiety. And then sessions 2, 3, and 4, you're doing kind of straight CDI coaching. We're coding them, trying to get them to mastery, although they don't have to meet mastery criterion because it is a time-limited treatment instead of a mastery-based criterion. And then in sessions 5 and 6, we're still doing CDI with them, but then we start having them engage their child in low-level exposure tasks for the anxious situations, kind of those that can sort of happen to the child. And then in session 7, we do a dad's teach, which is basically kind of our version of PDI or VDI with these children. And then we conduct more sessions using those dad skills, CDI skills, and getting them to do exposures to the numbers on their hierarchy. So DAD stands for, you first describe the feared situation. So the parent would describe the situation. Oh, I see you're, I'm talking with a friend over here, and I'm going to move closer to them. So then they approach the feared situation. So the parent is modeling approach behavior. and then they give a direct command for the child to approach the situation. So please come stand
Great.
next to me.
You remember last
And then
week when
what's
we talked
different than
about
your
how hard
standard
certain things were
PDI is
and
that
maybe
there's
how
no
a
timeout if
little
they
bit
don't
easier
follow
certain
through
things
with
were?
that command. We basically kind of
Yeah, a little bit.
actively ignore any
So what we'll do
avoidant behavior,
is we're going to
and then we
build
actually
up
will go back and
from the
restate the
easiest
command
thing,
again, giving them
thing
additional
that the
time
worry
to
monster asks
comply.
you to do.
However,
And then we'll
we
go
will
all the
also
way to the
break down the
hardest things
task
the worry
into
monster
easier
asks you to
components.
do.
If we're seeing a lot
That
of
is hard to
resistance
boss
and
back.
avoidant behavior, then we will try
That
to break
makes
it
sense.
down
So
into
maybe
a
we'll
smaller
start
direct
with
command for them to
last
engage
week.
in that practice. So
So
there's definitely
last week,
some debate about whether or not to
I think we
implement
asked you
timeout for
about
these kids when they're truly
what if you had to be
anxious
alone in
and
a room
frozen
without
and
mom or
can't
dad?
move.
Trying to get around to where
And so we now, instead of sort of using them as a set sequence,
So,
we're
for
using them
example,
as a set of
Ollie,
skills that parents can use to try to help promote their child to approach these situations. John Comer and colleagues
And go ahead and create
tested
your
this.
webcam on again.
And then there's another paper by Cooper Vince and our team. There was a case study of a 6-year-old boy. And you can, let me show you the creation. Do we have time to do the fear ladder? Okay, so we can go back. I can highlight what we did there. Yep. Okay. So real quickly, within the WebEx platform, there's a share function, and we use that quite a bit in all of these trials to we can create Google Docs, and then we can share those Google Docs without any identifying information, and have them be able to, you can pass the controls back and forth and let them kind of type into the document so that you can see what, just like what we're doing here, they can type in, we can type in, we can kind of pass that control back and forth to the client, as well as when you're showing ECB graphs, we show kind of fear and avoidance hierarchy graphs in ICALM, and so you can actually pull those up and show them to the families just like you would if they were here in your office in person. So you can see for within the case study that the fear and avoidance hierarchy, the numbers obviously came down significantly over time through to session 14. Both mother and father report, and then you can see that in addition that the CGI severity rating went down also for the child. So right now we're currently in a randomized waitlist controlled RCT, again with 40 kids who are getting randomized to either the internet based CALM or a waitlist. And
Jamie,
we're
thanks so
actively
much. I see
recruiting
Jen
right
Wish is
now,
getting her
both
question
here in
ready.
Florida and
I'll
up
tell
in
you that
Boston. And then
you'll
they have
probably
follow-up
validate this.
appointments as
Anything that
well.
can go
So
wrong will go
obviously
wrong,
there's
and
still some
probably
things
in the
that have
first
to be
time
resolved
that you
and
try
things
to
that
do
are
this.
getting worked out within the legal system as well as security
I
of these types
enjoyed
of services,
yesterday a
especially with
2-hour
licensure,
PDI2
that
session.
we
I
can
had a
provide these
trainee sitting
services
with
to
me
people
right
all
next to
over
me
the
in this room.
country.
44
It's
minutes,
just
it was
what
going
we
great. We
actually have
got
a
a warning,
license
the
to
kid
do.
complied. She said, I
It
have to go
still
to my next
is
appointment. A minute
still not
45
figured out.
started. The
Hopefully
hour and
one day
15-minute
as
timeout that went
psychologists we
from
can have
the
sort of
basement to the kid locking
universal
himself in his
licensure
bedroom,
coverage,
locking himself in
but
another
there's obviously
bathroom.
trade-offs to that
But you
and
just kind of
billing
have to
and
hang in there and
insurance issues.
expect that and kind of go with the flow.
So
I think by
obviously
making sure to
we
have the
make
separate audio
very rapid
connection,
changes in
you're good to
technology,
go
and
whether
we
you
kind
have
of
the
have to keep
video
thinking
or not.
um, several steps ahead of where technology is going. I mean, some of you may not even know what the VHS tape is. So things to kind of keep in mind are really trying to kind of stay flexible with what you're able to provide. Here's my contact information and our Mint website as well as the CCF website. We have a lot of different services here at FIU. And if there's any questions, then I am happy to take those. Thank you. Yes. How do you complete the
In terms of time management of a session compared to a traditional session, Tiffany was asking how you complete NECB. I'll describe what our procedure is. I'm curious what you do. I send an NECB and I rip up one on
Yes.
this end when we do it to comply with the not ripping off the company that owns the copyright.
Yes, exactly. So
Um,
we tend to have parents
but how do you do time
know that to
management
have
in
their
terms
phones
of
ready to go,
when
to
you do
have an
your
extra kind of
check-in
set of
and where
headphones,
the kid is while you're
so
doing the
that in case
check-in, and do you
anything
do
is
some things in advance of the
kind
appointment
of
and the
goes
checkout?
wrong. And
How do you
again, we've
manage
had
the
sessions
60
where
minute
for some
session?
reason there's just WebEx difficulties, can't figure out why. Sometimes things just don't connect. So we have used FaceTime in a pinch, especially if like a family is going out to the grocery store to do public practice. We want to be able to connect with them. So we will sometimes, and we just ask permission ahead of time and say, we're trying to use the more secure format, but if we can't, then obviously sort of using the time that we've set in advance is our hope to be able to, to get the task in and to do the live coaching seems more important. So, and most families have been fine with that. Yeah, great question. So, in terms of the ECB, we have our families complete all of their measures online through either Qualtrics or RedCap, and RedCap is where we're moving everything to at this point, which is a HIPAA compliant database system that does really nice data collection. And so we send them an email to a link, and everybody has an ID. So it's all completely confidential. So that's how they complete the ECB, and they get it before each session. And so then the therapists go on and look at the data ahead of time and complete the graphs so that we can see how they're doing. And then in terms of managing time, it is a little bit more complicated because you have kids in their own environment. Sometimes you've got siblings running around, or somebody's making dinner. You got the baby crying in the background. So kind of like what you would do in your in-clinic PCIT. Sometimes we got the baby in mom's lap while they're trying to engage in, CDI practice. We do try to have the child engaged in a task while we're doing the check-in. So either they're already playing with the toys so that we can talk separately, and the parents are wearing the headphones most of the session. If we feel like if the kid is really interested in who we are on the other end, then we will go off headphone and come through the computer speakers and say hello and check in and say hi to them.
Yeah.
But most of the
And
time
let me help
we're
with the time
on
management
the
because I know
parents'
people
headphones
drop
so
off
that
like
they're
flies at
hearing
one
us
o'clock.
directly, and the
Who's
child is
doing the
engaged in
trial up in
something else, and then
Massachusetts?
the parent goes and gets them and brings them into the room. Other times we do have
You've heard.
either phone check-ins prior or if there's something that we need to do, we have built-in ASAP sessions, which are things that, in case there's some other sort of bigger crisis, that we have time to manage that in a separate
Okay. I'm putting that
session.
in.
And then similar to the checkouts, most of the time we have families let the kid know that after their time is up for the session, we've had a lot of families like say they can go play a game on the iPad, or which is kind of reinforcing for the child to sort of stay in the session with their parent. The other thing that's challenging is having uh, like a playroom or toys everywhere, not running out of the room. So sometimes we'll have the parents take the toys into like their bedroom and close the door so that again you've got
That's what I do
some
as well.
sense of it being separate and a special
That's what I
space
do as well.
and time for them to play.
What I will say to you who are
So I'm
contemplating
looking
doing
at
this in your
some of these
practice setting, whether it's a
questions
clinic or
also that are
private practice,
coming in.
whatever, do a test run with your colleagues before you
Sure.
attempt to do it with
Yeah.
a family so you can work out some of those kinks. Jamie, thank you
So
so
it is
much.
through it's through CARD. It's through
Families as
BU,
well.
and
Um,
so Donna Pincus is
Jamie is
overseeing
very
that.
gracious.
So it's through
This is a particularly tough
so
time in
John
the
is
life of
running it
anybody in
down here at
Florida as
FIU,
a mom with
and
sick
the age
kids and a
range
sick husband.
is
It's
3
challenging.
to 8.
So, and just ran a conference,
So
all
they
of
can
the above.
call BU and
Thank you
ask
so much.
for
I
the
want to
Calm
just put in a
trial.
plug. Our next
Um,
Lunch and Learn is March 9th, a week from today.
and then
My
in terms of private
former
practice,
student
most people
also
don't
and
even
colleague
really
and
need the
friend,
Bluetooth
Dr.
and don't
Dominic
really
Osiello, will be presenting
you
on
don't have to
executive
use it.
functions of the pediatric
You can
brain.
connect the Bluetooth to the
Be a great
computer,
one
so then the
to
parent
come
isn't
back to us
having to
for.
use their phone
Jamie and I are both
for the live
reachable by
coaching. But we
email
have
and love
tended
to
to
help people
kind
move
of
stuff along.
defer back to
And
using the phone
so
for
thank
most
you again,
sessions, just
and
because then we know we
we will
have
see
the
you hopefully
audio
next week.
always.
Jamie, say hi to
And
everybody on
sometimes
your
the
end.
Bluetooth cuts out, and then they don't
Thanks
know
all for
whether you
participating.
got lost or they got lost, and so we've definitely used the